Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. So let's resume our topic. We are talking about, as in previous video, we were talking about the depression, and let's resume our previous point number 11. But before going to start my point, I would like to let you know, remind one point once again that must keep in your mind the mode of action of antidepressive drugs, because its mode of action is actually acts as a key for solving various type of question which will you face in exam. As you know that in depression, basically we use selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, 5-hydroxy F5HT receptor modulators, and monoamine oxidase inhibitors. All these drugs do one thing, that is the increase the level of norepinephrine and serotonin in synaptic left, as it is very beneficial for us, and this is actually treatment goal for the depressive patients. But side by side, they also block the muscarinic receptors, histaminergic receptors, and adrenergic receptors. So here is a series of interaction starts. A person who is concomitantly taking the medicine relevant to these classes for their respective conditions, they would definitely face interaction with them. So there is a need of specific dose adjustment. So we will keep on discussing the examples of these interactions, and we will, in this way, we will finish this antidepressant chapters. So let's resume our point number 11. It is about, it's also talk about the side effect of tricyclic antidepressant. This is the side effect of antidepressant drugs, that is the sedation and anticholinergic side effect. I know, as you know, that it block a H1 receptor, histaminergic receptor, which causes sedations, as well as anticholinergic effect. As you know, wherever the cholinergic receptors are there, you can easily classify. Once you just need to go and review our previous series of video for autonomic nervous system, then you will easily understand that the muscular receptors of eyes and in salivary gland and gastrointestinal tract and excretory system, wherever the muscular receptors, there you will face, you will easily understand about the its anticholinergic effect, and you can easily understand about that. So we will some of the examples we will mention in upcoming points. So I was telling about tricyclic antidepressants, and it is contraindicated with the guanethidine. Guanethidine is alpha 2 agonist, and it play a key role in treatment of hypertension. On the other hand, this tricyclic antidepressants act as an antagonist at the alpha 1 receptors and adrenergic receptors. So there is a when these are contraindicated. Point number 12 is about prescription. Just keep in one thing in your mind, that once you are prescribing a patient with tricyclic antidepressants, with monoamine oxidase inhibitors, with the phenylephrine, that is the alpha agonist, with the ephedrine, with the amphotericin B, and then side by side, patient is also consuming tyramine containing food. Now just look at this. Tyramine containing food also increase the level of these neurotransmitters, and tricyclic antidepressants are and monoamine oxidase inhibitors are increasing its availability in presynaptic neuron and into the synaptic cleft. So as well as he's using ephedrine, phenylephrine, which is actually acting as an energistic effect on the, which is acting on the adrenergic receptors. So in a result, it will generate a symptom like a high level of these you can say catecholamine and serotonin. So this its high level will ultimately generate a symptom like hypertensive crisis. Just you can compare this situation with the situation as we discussed about in autonomic nervous system, about the pheochromocytoma, where in the middle of our adrenal gland a tumor develops. Because of that, norepinephrine level uncontrollably increase in the blood, and it's caused this effect. So for its treatment, we recommend the use of medicine, that is the alpha blocker. One of its example is phentolamine. So whenever the situation arises here, then there must its management required to stop the tyramine containing food and manage the patient with an alternative. And if it is necessary, then use the alpha blockers to avoid the negative effect of these drugs. So this was all about point number 12. One thing I would like to clear is, according to its side effect, that monoamine oxidase inhibitor. In upcoming lecture, when we will discuss about the cardiovascular system, then we will also I will let you know that how reflex tachycardia work. When blood pressure drops, then our body automatically tries to increase the level of blood. In that way, this is the situation arrives. This is, you can say, a protective response. This is known as a reflex tachycardia. When a person goes in hypertensive crisis or in any condition, once a patient is being used, is using tricyclic antidepressants, he will definitely go in tachycardia. But a person who is using monoamine oxidase inhibitor, it's not side effect of this drug. So let's move on. Point number 13. It's about the sertraline. Sertraline is a selective serotonin reuptake inhibitor, and its dose is 250 to 200 mg per day. And the point here is that sertraline is SSRI, and it causes hepatotoxic drug. If a patient is suffering from if a patient's liver is compromised, then don't recommend sertraline because it causes hepatotoxicity. Point number 14. It's about a drug of tricyclic antidepressant. Example is amitriptyline. As I told you, its dose is about 150 to 300 mg per day, and it was about its antimuscarinic, constipation, blurred vision, and these side effects like antidepressants causes tricyclic antidepressant causes antimuscarinic, constipation, blurred vision, postural hypotension. These are the side effects of this tricyclic antidepressant. As you know, you can easily understand because of its blockage of muscarinic receptor. It causes these side effects. And blurred vision and constipation, as you know, blurred vision because its M3 receptor blockage will result into the blurred vision, and the receptor of gastrointestinal tract will result into the constipation and postural hypertension. Whenever you use these medicine for the management of hypertension, when you will discuss the chapter of cardiovascular disease, then you will understand there that whenever we use the autonomic nervous system or autonomic nervous system drug for the management of hypertension, or any drug which deal with the muscarinic adrenergic receptor, whenever you use them for the controlling of hypertension or the impact on hypertension, they will, one side effect is common, that is the postural hypertension. And no, I would like to tell you about the venlafaxine. It belongs to the class of drug that is the serotonin norepinephrine reuptake inhibitor. Its dose is 75 mg to 375 mg per day. 75 mg to 375 mg per day. Its adverse effect is to increase the hypertension. It causes raise of blood pressure. This is its side effect. This is all about the point number 14, and point number 15 is about the tyramine. The longer food take to process, higher the tyramine. As long as as much you process the food, it will take there will be higher chances of tyramine content in that food. So let me mention you some of the examples of tyramine containing food, that is the cheese, beer, wines, and beverages. And these are the foods which you must need to avoid, especially with the monoamine oxidase inhibitor, because monoamine oxidase inhibitor metabolize this norepinephrine, serotonin, and keep their level in a controlled limit. But once you are using monoamine oxidase inhibitor and using these tyramine foods, it means that you are uncontrollably increasing the level of catecholamine, and there is no check to control its level. Then there is a huge chances of side effects. So it is contraindicated to use monoamine oxidase inhibitor side by side tyramine containing foods. And it's a rule to identify the tyramine food. More the food you process, higher there will be chances of tyramine content in that. But red meat isn't contraindicated with monoamine oxidase inhibitor because it is clear that if it isn't contraindicated, it means it don't have a very low amount of tyramine content in that. This was all about point number 15. So point number 16 is about bipolar depression. As I told you in previous video that it's a depression which contains both state, manic stage as well as a depressive stage. It is treated with the use of lithium carbonate, and we use sodium valproate as well as carbamazepine. Carbamazepine and valproic acid are anticonvulsants, and lithium carbonate are also one of its treatment plannings. But I'm not here to discuss about its treatment plan. I just want to let you know about the interaction about the lithium carbonate. When you are prescribing lithium, then must keep in your mind that there shouldn't be restricted supply of sodium to that patient, because sodium play a key role in the clearance of lithium. Once there is a low content of lithium sodium, then it will increase the chances of lithium accommodation in patient. It will causes adverse effects. And for example, if a patient is already using diuretics, then don't recommend this any medicine which contain lithium content. And for example, if lithium content increase in the body, what would happen? It will lead towards the convulsions and nephrogenic diabetes in spiders, which later on will be managed with the use of vasopressors. And this was all about that point. Just keep in your mind that once patient is using a medicine which containing lithium, then there must ensure that patient should is getting adequate amount of sodium content. This is all about point number 16. Point number 17 is about another, once again, example of phenylcypromine. That is the example of monoamine oxidase inhibitor drug. Its dose is 30 to 60 mg, as we discussed yesterday, and used. Just the point here was that exactly when you are using this drug, you have to keep diet and drug in check. As I have told you earlier, that a monoamine oxidase inhibitor contraindication with the tyramine containing foods, and as well as other you can say drugs of antimuscarinic, adrenergic, and histaminergic drugs. So point number 18 is about the once again another example of a monoamine oxidase inhibitor, that if you are using uh, iproniazide is an example of monoamine oxidase inhibitor drug. If you are using it with the pseudoephedrine, then caution must be applied, because we need to be careful while using this combination. Point number 19 is about the about the dietary precautions. As you know that procarbazine is a monoamine oxidase inhibitor. Dietary precautions required. This point is again the repetition of the same point. As I told you that this is the key is same, that you have to be keep the level of tyramine as well as the other muscarinic, adrenergic, and estinergic drug in check, because most of the question will be either by switching will be asked from this section, and here you need to be very conscious, and you should know about the examples of all classes of these drugs so that you can easily tackle any sort of question. So dietary precaution is required, as you know, whenever you're using the MOI containing drugs, either you are using phenylcypramine or procarbazine or iproniazide, any drugs, example from monoamine oxidase inhibitor, it doesn't matter. Basic concept will remain same. Point number 20 is about phenylzine. Phenylzine is a drug. Its dose is 40 to 90 mg per day, or you can say 45 to 90 mg per day. And it's also mentioned that be careful about using this drug side by side the tyramine containing food. Point number 21 is about the example of tyramine, and example of tyramine, as I told you earlier, that cheese, bees, wines, and beverages, and avoid this food with the prazoline drugs. Prazoline is also example of monoamine oxidase inhibitor. Just keep in your mind that how the examiner is setting the exam. They are just using one concept and mentioning various example to ask about the to get an analysis of your. Is just switching the questions to get a view of your command over therapeutic knowledge. Let's move on our point number 22. That is about the nifazodone. It's a 5-HT receptor modulator. Its dose is 300 mg to 500 mg per day. Its side effect is hepatic failure. If a person is hepatic failure, you don't recommend this drug. Nifazodone. It's an 5-HT3 receptor modulator. Point number yes, exactly. 22 remaining part is that it is also contraindicated. Just keep one thing in mind, that 5-hydroxy, you can say 5-HT receptor modulator is contraindicated with tricyclic antidepressants, with monoamine oxidase antidepressants, inhibitors, and antihistamines. These drugs are contraindicated with them. Example of antihistamine: terfenadine and S-tenizole. These are the example of antihistamine drug, and just simple thing is that these drugs are also contraindicated with each other. Point number 23 is about the you can say, yes, exactly. Point number 24 is about the monoamine oxidase inhibitor. Its implication like psychotropic drugs. It's the psychotropic drugs, antidepressive drugs, and antileptic drugs. Its side effect is basically tremor, hyperthermia, and hallucination, and anticholinergic side effects. And here I think so. I don't need to repeat this example of anticholinergic side effects. That is also known as ejaculation failure and xerostomia and constipation and blurred vision. So this is all about it. Deal with the psychotropic drugs and antileptic drugs and antidepressive drugs. Monoamine oxidase inhibitor is used for that. Point number 25 is about the monoamine acid side effect. As I have told you about with he is just telling about the monoamine oxidase inhibitor. It doesn't cause tachycardia, but tricyclic antidepressant causes tachycardia. This is the side effect and difference. Point number 26 is about some of the example and doses of monoamine oxidase inhibitor. That is just for your reminding. I just want to repeat it. That phenelzine is dose ranges from 45 to 90 mg per day, and phenylcyclamine its dose is 30 mg to 60 mg per day, and slegilene its dose is 20 mg to 50 mg per day, and isocarboxazide its dose is 30 to 60 mg, and some other example are miclobemide and iproniazide. These are the example of this. The main drugs are phenelzine, phenylcyclamine, slegilene, and isocarboxazides. These are the example of the drug. Keep one thing in your mind that levodopa, once patient levodopa is also contraindicated with the monoamine oxidase inhibitor drug, and it increase the. But when you are using this in combination, it also this increase the oral hypoglycemic drug activity. Simple is that levodopa is contraindicated with the monoamine oxidase inhibitor drug, and increase in it because it increases the activity of hyperglycemic drugs. This is point number 25, and now our next point is about the bipolar depression. I have already tell you about its treatment plan, and the main thing was about we used two anticonvulsant drugs, that is the valproic acid and carbimazole, and lithium for its management. And for lithium, as I have already told you, that keep in mind to maintain the supply of adequate consumption of sodium and avoid use of diuretics with that. Point number 28 is about the imipramine. Its dose is imipramine is it's an you can say tricyclic antidepressants, and its dose is 150 to 300 mg per day. Its question is about the metabolites. It is metabolized by demethylation, and finally it gives rise to desmipramine. This is all about the metabolite of imipramine, and it is specifically used for enuresis and hyper kinetic kits. This is the its implication, and this is all points. So I think so video is going too long. I just close my recording here, and the next part 3 of central nervous system will be resumed in next video. Thank you so much for listening, and please guide us from your suggestion, because we are also a student like you, and subscribe me, because your subscription is very appreciating, is actually very appreciation for me. Thank you so much.